Hey everyone, and welcome. If you've ever had a knee that just started talking to you, with a twinge here or a sharp pain there, it can feel like a real puzzle. Well, today we're going to put on our detective hats, piece together the clues, and figure out what's really going on inside that knee of yours. So let's get right into it. You know that sound, that sudden pop during a pickup game, or maybe it's that slow, grinding ache that just seems to hang around. These aren't just random feelings. Nope. They're messages. They are actual clues your body is sending you, and our mission today is to learn how to crack that code. First off, let's just take a second to appreciate what our knees go through every single day. Depending on what you're doing, walking, running, jumping, that joint can be supporting up to 5 times your entire body weight. Think about that. That is an incredible amount of force, and it really shines a light on why this one joint can be so easy to injure. So, to really solve this thing, we're going to follow the stories of 3 different people. Think of it like a little medical detective show. We'll look at their history, we'll examine the clues from their physicals, and we'll see exactly how doctors piece it all together to figure out what's what. Okay, our first case is all about that sudden, out-of-nowhere injury. Let's meet Mr. H. He's a carpenter, and his workday took a very painful and very sudden turn. All right, let's look at the clues together. So, Mr. H is 55. He's had a previous ACL injury, which right off the bat puts him at a higher risk. Then, the big event. He lands awkwardly coming off a ladder, he hears that classic, unmistakable pop, and boom, immediate pain and swelling. You see? This specific set of clues is already pointing us in a very clear direction. Now, when a doctor hears a story like that and suspects an ACL tear, they don't just guess. They have specific tools. And one of the most important ones is in a machine. It's a physical exam move called the Lachman test. It's designed for one thing and one thing only, to check the health of that super important stabilizing ligament, the ACL. So here's how it actually works. The doctor has you lie down, they bend your knee just a little bit, maybe 20 or 30 degrees, then they'll stabilize your thigh bone with one hand and gently pull your shin bone forward with the other. If there's a lot of give, a kind of mushy feeling compared to your good knee, well, that's a really strong sign that the ACL is torn. It's simple, but it's an incredibly powerful diagnostic tool. Okay, so the exam is pointing to an injury. What's next? Imaging, right? But here's the thing. Not all imaging is the same. An X-ray, fantastic for looking at bones, checking for fractures, but for something like a torn ligament, like in Mr. H's case, the MRI is the absolute gold standard. Why? Because it gives this beautiful, detailed picture of all the soft stuff. The ligaments, the meniscus, all of it. And there you have it, the story of that telltale pop, combined with what the doctor felt during the Lachman test. It makes the diagnosis pretty much crystal clear. A probable ACL tear. Case closed. Now let's switch gears to a totally different kind of knee problem. All right, we're shifting from a sudden pop to a slow, grinding pain. This is the story of Miss K. She's a waitress, and her knee pain didn't happen in a flash. Nope. It built up, slowly, over months, until it became disabling. The clues for Ms. K paint a very, very different picture. She's 60. Her job has her on her feet all day carrying heavy trays. The pain has been getting worse for months. But here's the kicker, the crucial clue. The pain used to get better when she rested, but now it hurts even when she's trying to sleep. That right there points to a classic wear and tear process. And that wear and tear process, it has a name, osteoarthritis, or just OA. And it is the single leading cause of pain and disability all over the world. The analogy of the tread wearing down on a tire is just perfect. That's exactly what's happening to the smooth protective cartilage that's supposed to cushion our joints. It's just slowly breaking down. And when we look at the major risk factors for OA, Miss K's story starts to make even more sense. She ticks a bunch of these boxes, right? Age over 50, she's female, and her job puts a ton of load on her knees day in and day out. Now, these things don't guarantee you'll get OA, but they for sure increase the odds. Now, here's something that might actually surprise you. For a classic case of osteoarthritis like Miss K's, the diagnosis is what we call clinical. That means a doctor can often figure it out just by listening, really listening, to the patient's story and doing a good physical exam. A lot of the time, you don't even need an X-ray to make the call. So what's the first thing you do for OA? You might think it's reaching for a bottle of pills, but you'd be wrong. The best, evidence-based, first-line treatments are all about empowering you, the patient. We're talking targeted exercise, weight loss to take some of that load off the joint, and just learning how to manage the condition yourself.
And this brings us to a really crucial point about what doesn't work. I want you to listen to this quote. It's straight from the source material, and it is powerful. It says that despite all the ads you see, big studies have shown that common supplements like glucosamine and chondroitin have, get this, no meaningful benefit over a sugar pill.
So what about surgery? A total knee replacement can be absolutely life-changing for many people, but it's so important to have realistic expectations. The data shows that a pretty big chunk of patients, somewhere between 10 and 34%, still report having long-term pain even after they've had the surgery. It's a great option, but it's not a guaranteed magic bullet.
All right, our final case is, well, it's in another league entirely. The tone here really has to shift, because this isn't just about pain. This is about a potential medical emergency. This is a big red flag. Let's talk about Mr. B.
The clues for Mr. B are just screaming urgent. He has other conditions like diabetes and rheumatoid arthritis that already put him at a higher risk for infection. But the key signs, the things you cannot ignore, are the sudden onset of a single knee that is hot to the touch, visibly red, swollen up, and so painful he can barely walk. This is the body's fire alarm going off.
This quote right here, this might be the single most important takeaway from this whole explainer. It's a fundamental rule in medicine. When you see a single hot, red, swollen joint, you have to assume it's a serious infection until you can prove without a doubt that it's not.
The scary condition we're worried about here is called septic arthritis. This isn't just a little inflammation. This is a full-blown bacterial invasion inside the joint space itself, and it is an absolute emergency because those bacteria can literally eat away at the joint cartilage, causing permanent, irreversible damage in a very short amount of time.
So how do you prove it's an infection? You can't guess. The gold standard, the one definitive test, is to put a needle into the knee joint and draw out some of that fluid. Analyzing that fluid, the synovial fluid, is the only way to be 100% sure there are bacteria in there and to get the right treatment started immediately. So there we go. We've just walked through 3 totally different stories, right? A sudden pop from a tear, a slow grind from wear and tear, and a hot red flag signaling a dangerous infection. Each story was told through its own unique set of clues. You see, understanding these different patterns, the pop versus the grind, the mechanical problem versus the red-hot emergency, it helps all of us listen to our own bodies more carefully. Context is absolutely everything. So the next time your knee starts talking, take a second and ask yourself, what story is it trying to tell me?